So, cerebral palsy is the commonest cause of childhood dystonia. In point of fact, of all the cerebral palsies, dystonia is said to represent perhaps 10 to 20% of cases of cerebral palsy. If we take the conservative figure of 10% of cerebral palsy has a dystonic manifestation, then we can begin to understand how many children and then how many adults are affected with dystonic cerebral palsy. A conservative figure for the incidence of cerebral palsy is 2 for every 1,000 live births in developing countries. So for the United Kingdom, which has a population of about 60 to 65 million people, there are 600,000 births a year, and 2 per 1,000 comes to 1,200 cases every year. Now, in order to make a diagnosis of cerebral palsy, you have to observe the child over a period of 1 to 2 years to make sure that what you think is a movement disorder isn't actually part of an atypical development pattern. And so let's assume that the first 2 years are devoted to establishing a diagnosis of cerebral palsy with confidence. The remaining years of childhood would be from the age of 2 to 18, so 16 years. Now, if you assume that all of those children live to 80 years of age, which is a big assumption, which I'll come back to later, that would be that there are over 90,000 individuals in the UK, maybe 100,000, with dystonic cerebral palsy. That's separate from all the other causes of dystonia that occur after the age of 2. And I'll come to that in another section. So just cerebral palsy and dystonic cerebral palsy accounts for perhaps 100,000 individuals with dystonic cerebral palsy. So as a group, they occupy very much the center ground of need. One of the difficulties with dystonic cerebral palsy is that as soon as you leave the childhood care programs, you meet with adult disability services which are much less well-resourced, and governments tend to consider adults with early onset disabilities as much less of a priority. So it's very important that the children and the young people with dystonic cerebral palsy are set on the correct route of appropriate management, which can then be exported to their adult counterparts. Cerebral palsy has no specific cause. There are many, many different individual causes of cerebral palsy, of which the commonest tend to be related to early life in the womb, or at the time of delivery, or soon after delivery, or in the first 2 years. And the immature brain is more vulnerable to a whole series of damaging processes. Lack of oxygen to the brain is one of the rarer causes of dystonic cerebral palsy. Much more common is a disturbance to the white matter of the brain, the cabling within the brain, during the first 40 weeks of life in the womb. Prematurity is also a common cause of dystonic cerebral palsy, and what's interesting is that the brain scans of children with dystonic cerebral palsy seem to be much less damaged than the brain scans of children who don't have dystonic cerebral palsy. And that isn't so surprising because the dystonic brain has to have some intact neurology in order to express dystonia. The children who aren't dystonic are generally very weak, and they have brisk reflexes and very little in the way of voluntary movements. The dystonic children have too much movement and too much posture, and that means that a large part of the motor system must be intact in order to express that. So, paradoxically, a child with dystonia has a motor system which in many ways is in good working order. It's just being given the wrong signals, why the body is out of control. But the body is moving, but in an out of control way. In the commoner causes of cerebral palsy without dystonia, it's the lack of movement, it's the weakness, it's the floppiness that is a big issue. So these are different ways of recognizing what is and what isn't dystonic cerebral palsy. The whole issue of the management of dystonic cerebral palsy is very similar to the management of a cause of childhood dystonia from other causes than cerebral palsy. It has to be focused on the comfort of the child for sleeping, for sitting, for learning, and for other activities and participation. But because the dystonia affects the very early growing child, there is a much greater risk of deformity in dystonic cerebral palsy. We looked at how common deformity in the childhood with cerebral palsy actually is. And we found that by the time a child is 5 years old, half of those children with dystonic cerebral palsy will have a deformity. And by the time they're 20, all of them will have a deformity. So this is another big challenge to medical science, which is how to improve the dystonia in children with very, very early onset dystonia. And it's quite clear that if we want to prevent deformity, then we have to intervene before a child is 5, and typically earlier than that. Medication management is really unsatisfactory because almost every child who has had one of the standard medications will have had side effects from those medications. The two principal side effects are drowsiness or somnolence, which takes the edge off the thinking abilities of the child. If you turn down the volume on the dystonia, quite often what replaces dystonia is floppiness. So we can see with a child who falls asleep that in fact the body can relax very well. If you turn down dystonia, what happens is that you can replace it with floppiness, and then this can be associated with excessive drooling, which isn't helpful. If a child can no longer hold their head up, then they can't look forward, they can't look at people, they can't look at screens, they can't carry on with their activities. So a dilemma that often faces the child with dystonic cerebral palsy is they have arms which are very unruly, and in order to reduce the involuntary arm movement, a medication is given which then makes the trunk floppy. So you convert a child who is moving about but looking forwards into a child who may be still but then can't function. And this is why a lot of the medication that is used in dystonia creates another problem: hypotonia and floppiness. So the majority of medication for dystonia, like benzodiazepines, baclofen, trihexyphenidyl, will cause this to happen. Another reason why the medications are less successful in children is that because their dystonia is so severe, larger doses have to be used. Now, it is said that children tolerate large doses of medication more easily than adults, particularly trihexyphenidyl, but that is something that can be challenged. They tolerate larger doses because they have to have larger doses. And so we accept the need for larger doses of medication. And we also accept the side effects, reluctantly. The big debate currently about non-pharmacological means of improving dystonia is about the possible benefits of deep brain stimulation in dystonic cerebral palsy. And it appears clear that as rigorous a selection procedure for the possible candidates is required, one of the clinical ways of distinguishing who would be a good candidate is to ensure that the child doesn't have any evidence of spasticity, which is when the child is actually weak and the reflexes are brisk. So if you eliminate those children, then you stand a better chance of improving dystonia with deep brain stimulation. In order to be more rigorous, our centre employs a technique for measuring how the motor system is working using pulses of magnetic stimulation of the brain to show that the motor pathways are conducting normally. And we also measure the sensory pathways to make sure that the two major motorways from the brain to the body and from the body back to the brain are functioning. And we found that if we can demonstrate that these systems are up and running, then we have a better success rate in managing dystonia. But in fact, what we need is more interactive systems to assess how the brain and the body are interacting. And so we're now looking at measuring brain waves and muscle waves and seeing how the two wave patterns are interacting. This is called corticomuscular correlation. And there's definitely a very important relationship between the brain and the muscles. And by using these techniques, we're hoping it's going to be possible to determine before an intervention such as deep brain stimulation, which requires placing electrodes deep into the brain, into the basal ganglia. We're hoping that using preliminary assessments such as corticomuscular correlation techniques will help us to determine favorable predictive patterns in all children with dystonia, but particularly in children with dystonic cerebral palsy. if we are just looking at the child clinically without these additional techniques, it's clear that a child with very active movements that are involuntary is a better candidate for deep brain stimulation than somebody who has stiff postures that don't vary. We call this fixed dystonia. Fixed dystonia is much less amenable to deep brain stimulation than mobile dystonia, where the body is changing position a lot. For a small group within the dystonic cerebral palsy category, deep brain stimulation may be helpful, but it is important to try and eliminate cases where the DBS will be less successful. Those will be the cases that have signs of spasticity, which, remember, is weakness, floppiness, as well as brisk reflexes, because that would suggest that the major motor pathways from the brain to the spinal cord are not functioning. So if you eliminate those cases and you supplement that search by doing special electrical tests to ensure that the motor pathways from the brain to the spinal cord are functioning with transcranial magnetic stimulation, and you also ensure that the sensory pathways from the body up to the brain are intact using sensory evoked potentials, then you stand a better chance of having a group of children who have, as far as can be determined, the least possible brain damage. The reverse is true, that the more damaged the brain appears to be, then the less successful the deep brain stimulation will be. And in fact, the best candidates will have no evidence of brain damage at all. What's interesting is that perhaps 15 to 20% of children with cerebral palsy don't have any signs of brain damage, even though they satisfy all the other criteria for having a motor disorder that's of onset under the age of 2. And we think this is because the damage is very subtle, or it's affected the way the brain has organized itself so that it maintains the early infantile postures as the dominant posture and movements, and won't let in the newer, more functional movements that are necessary to make progress in life. Nevertheless, it's these children that may benefit from deep brain stimulation, and for whom we have to do a very active search to find them within the group of children with cerebral palsy. It's often said that deep brain stimulation, which is a neurosurgical procedure, should be reserved till all other options have been excluded. And this takes time. And we've also commented on the fact that contracture and deformity will affect half of children with dystonic cerebral palsy by the age of 5. So we've got a race against time to prevent deformity, while trying to exclude other successful means of improving dystonia. And in no time at all, the children are already 5 years old. Another factor that is limiting the delivery of deep brain stimulation to young children is the general rule that deep brain stimulation is not offered under the age of 7, particularly in North America. And we have been looking at this in some detail, and in the past, one of the biggest reasons for delaying offering deep brain stimulation have been the concerns about the size of the head and the fact that the head will grow and the electrodes may then be pulled out of their target. But we have successfully used deep brain stimulation in 3-year-old children and now are beginning to work on the age group between 2 and 3. Largely because it's our view that if we want to give the brain a chance to develop more normally, when the brain is programmed to acquire new skills and functions, then we have to offer the neuromodulation with deep brain stimulation at a time when the brain is capable of doing that. And so this is a big task, and which will take years to establish. We don't just want to reduce dystonia, we want to improve the chances of a child will acquire useful movements, not just abolishing interfering movements, but actually to improve the skill base of the child by offering deep brain stimulation earlier.